So I'm going to try and talk today about participatory design as it is applied within healthcare, digital healthcare settings in particular. And I'm going to try to keep the focus more on the methods involved. Hopefully that'll be relevant and interesting to everybody rather than talking too much about my specific projects and research findings in the area necessarily, because what I want to do is give a sense for how you can engage with people, but more importantly, maybe what questions you should be thinking about when you are doing participatory design work. So I think we already covered most of this stuff. So I'm a lecturer in digital healthcare. I think it's worth saying my focus is particularly on participation in healthcare. So while I'm a computer scientist by training, ever since I did my PhD, I've focused particularly on the questions that come up when you're trying to bring people into the design of digital healthcare systems. In fairness, sometimes it's just a digital system, sometimes it's just a healthcare system in some of my research, but the really interesting stuff I think happens at the intersection of those points. Even within that area, I'm still a little bit more specifically focused than that because I have a focus on working with marginalized groups and particularly people living with cognitive challenges of some form. So a lot of my research focuses on asking questions about how you can open up participation to those groups and what the assumptions that we build into participatory processes are that might prevent them from engaging in the process. Today, what I'm going to try and do is essentially give an introduction to the area of design and participatory design from the perspective of human-computer interaction. So human-computer interaction being a discipline within computer science where we study how people and computers interact and the emergent effects that take place there. Within that area, obviously, we dive a bit more into the specific area around healthcare technology and the people who use it. I'll try to illustrate this with a discussion of, once we've got to these principles, I'll try to illustrate how we've applied them with different groups in the past and pull out some of the questions that that has led to. So, for example, really thinking about, what are the problems that we need to be aware of in following these processes and what can we do to amend the processes to make them more inclusive. But to start with, I think it's probably worth very, very provisionally talking about the idea of design in general. So a fairly famous quote that is often, or a phrase that we often use. So in human-computer interaction, there's a broad consensus that there is a single correct way to do design. Unfortunately, what we don't have is a consensus on what that single specific way to do design might be. So previously, we have tried lots and lots of different ways of working with people. There are many different design methods out there: user-centered design, participatory design, user experience design. These are all terms that you might have brushed up against if you've worked with a computer scientist to do design work in the past, or designers in other disciplines. Each of these methods is quite distinct and it's quite different in its way, but what we have developed through the British Design Council is something called the double diamond. Now, I don't know if people are familiar with this. Could I perhaps ask, would people mind just raising their hand if they have come across the double diamond for design innovation before with the raise hand button in Teams? I've seen one person who's come across it before. Most people don't seem to have, though. So I'm going to sort of assume that it might be worth digging into this just a little bit before we get started. So the double diamond is an attempt to formalize what happens in a effective design process, and the specifics of it change radically depending on who you work with, but some of the underlying assumptions, particularly the 4 phases that it moves through, are really quite useful to be familiar with. So there are 2 broad diamonds. There's designing the right thing and then designing things that are right. So essentially, the first diamond asks the question, what is the correct way to solve this question or problem or challenge that we have? And the diamond refers to the fact that initially our thinking diverges in a process of discovery. So we look at the briefing that we have, we pull that apart, we look into a large volume of secondary research, reading our literature on this topic, doing research on any underlying statistics that we might be able to access. And at the same time, we also do primary research, which is to say that we dig into the people who are invested in this area, the people with a connection to this problem. That group is a group that I'll classically refer to as stakeholders in the language of participatory design. And what this leads to is a large amount of data that is not particularly structured. And what we then need to do is start to pull it together. So we go through our first process of convergence as we start to properly define the problem. Okay, we start to think, we start to pull ideas together, and we eventually, hopefully, arrive at the point between the two diamonds where we know what the right thing to design is, and we enter into our next phase of making sure that that thing is then designed right. This again starts with a divergent process as we think of all the different ways that we can meet and fulfill our problem. We diverge here because we're generating lots and lots of ideas. And we then use small scale evaluations to try to narrow down our thinking a little bit, get to a place where we start to implement real solutions, and then we use things like lab studies and field studies, iterative prototyping, to narrow down onto a single system solution. The whole process goes from a place where we don't know and we know what things could be to a place where we do know and we know what things should be. That's the A to B process that's involved in design. So this is the general approach. This is applied by virtually, or rather this is processes run through by virtually every designer. But we have this second question now. So we, within the context of design, particularly look at doing participatory design. And participatory design is a pretty widely used term, and it's worth digging into as well because it is often confused. What I mean by that is that there are two concepts that most people mix together when they are talking about participatory design. There is what I call capital PED, participatory design, and then there's participating in design, lowercase p and d. Participating in design work and participatory design are very related concepts, but they're not the same thing. So specifically, participating in design can refer to any co-design activities. Anytime that you go to your stakeholders and you ask them for some feedback on what you are doing, that's inviting people to participate in the design process and have input into a piece of technology, telling you how we can, work or how we can improve that technology. Anything that touches on how we elicit information from people that we're working with touches on this idea of participating in design work. But participatory design, capital P, capital D, is something a little bit more specific, well, quite a bit more specific than that. So participatory design is about democratizing the environments that we create technology within. The core aim is to give a voice to everybody whose life is going to be impacted by the system that we're building. Are trickier questions. They require you to really think about who your stakeholders are and correctly identify all of the different voices within that community that you need to hear from. Participatory design is explicitly grounded in ideas of social democracy. It emerges from the Scandinavian labor movements of the 1970s. That's the actual history of it. It comes from the idea that it was essentially legally mandated, because of strong union movements in Scandinavian countries, that any new technology introduced into the workplace would consult with the workers who were going to be affected by it before it was introduced. This was meant to address fears of mass redundancy caused by automation within the workplace, but the legislation led to a suite of methods and ideas being developed that have come to produce very interesting, very useful digital technology as well. So we're thinking about this. What are the key qualities that make something participatory design? Because this is a question that I get asked quite a lot by students that I supervise. What's the difference? How do you know that you have done participatory design and not just let somebody participate in a design process? What I boil it down to is three things. So participatory design is a conversation with stakeholders, with space for genuine arguments and disagreements to take place, which should have equal benefits and control of the process shared between all of the different participants within the process. That leads to some really complicated things that you need to think through. So to explore it a little bit, the conversation with stakeholders means you have to be engaging in a dialogue. Specifically, that means that you have to be meeting with people multiple times over the lifetime of a project, and you should be meeting with them across the lifetime of the project as well. You shouldn't narrow the point that you engage with your stakeholders to a single place. You've built something and now you want to check if it's any good. You're designing something and you want to know what you're going to design. Narrowing engagement to one specific place in the process doesn't make something a participatory design process. So there has to be dialogue. There has to be a back and forth discussion. There has to be multiple meetings. You also have to have a space for genuine disagreement with the people that you are working with. You have to give them an opportunity to say, no, that idea is wrong. I don't like it. Throw that away. And you have to also be able to tell them, this isn't possible. We can't do what you want us to do. We have to make some compromises around this design. So this genuine disagreement is what really leads to high quality systems, services, digital interventions being built through this process. Because although it's difficult, this forces the designers of the system, the developers of a system, to engage with the real needs and values of the people that they're designing for. Finally, the equal benefits aspect of the process is very hard to realize. So democratizing the design and offering response to criticism is part of this. But another part that is often missed out in a lot of processes is the shared learning that the processes develop. So particularly when you're working with charitable groups or you're working with, let's say you're working with healthcare professionals, the process of engaging in participatory design, doing focus groups, running workshops with people, repeatedly sharing technology with them, generates a whole bunch of new understanding for them of the ways that they do work. And those things can be incredibly valuable, but as the people running a participatory design process, you should be committed to sharing that information and presenting it back to them. A quick side note as we move along, one of the real problems that I encounter in participatory design and writing about it and talking about it is that we simply lack a good verb for participatory design activities. You get caught up and you find yourself hitting all of these very awkward phrases. We co-designed an online platform to support caregivers. That's not quite right. We participatory designed an online platform. That's definitely wrong. We ran participatory design sessions to produce an online platform to support caregivers. That sounds better, but still isn't technically correct. And then you get to, we ran participatory design sessions to design an online platform to support caregivers. It's a massive mouthful when it captures what you're trying to say. This sort of thing is a constant nightmare when you are trying to write about participatory design, and it trips you up all the time because within design, you get stuck on this need to separate design as an activity from a design as a thing that you produce. So participatory design is not something that I expect is completely new to people. There are lots of very prominent participatory design policies. So there's plenty of evidence in the public sphere that participatory design has had impact for over the last 20 years or so. The most obvious one, which I'm sure everyone here is familiar with, is obviously PPIE, public and patient involvement and engagement. NHS England has some clear policies on that. I'm sure many of you are also familiar with the UKRI's collaborative research and co-production policies. And then there are now public consultation legislations on budgeting, certainly here within Scotland, for the process of participatory budgeting. So the ideas and the motivation behind participatory design has had a really wide-reaching set of impacts. But at the same time, those impacts have started to come around and perhaps cause more problems than they have solved. So the prevalence of demands to engage in some sort of co-design really create this problem that people within the community have started to coin the phrase ornamental PD to describe. So essentially, this is adding the language without committing to the work. This is a necessity for a lot of research proposals. You have to have some form of PPIE within it, but when you mandate that that work has to happen, what that does is it first, for some people, I think, undermines their enthusiasm to do the work, because now it's something they just have to do. So it can be seen as a barrier to getting work done. And then perhaps worse, it gets people accustomed to writing about doing this work who don't have much expertise in it, and then they are not able to see the benefits of running a PD process. We also see that in other places as well. So perhaps worse, participatory budgeting is sometimes deployed as a tool to essentially get people to start fighting over limited resources in political settings. There's a few papers now describing, particularly in Southern America, the quite cynical uses that participatory budgeting has been put to in order to create tension between different interest groups and to divert attention away from political decision making. Essentially, deploying the tool strategically to make sure that blame is shared between a wide set of different people, rather than the person in charge of a process being held accountable for its outcomes. We also find that there's the distinction between what we call co-design, participatory design, and participating in design keeps getting narrower. So every year I review more and more papers that conflate the idea of participating in design with doing participatory design work. And, you know, this gets to the point where people describe their work as participatory design because they ran a series of interviews about what people would like from a system before going away and designing the system. And that obviously robs virtually all of the benefits of a deep dialogue with your stakeholders throughout the development process. So this is a rough overview of participatory design. I want to talk now a little bit about what happens when we start to specifically apply it within the healthcare field. So when we build digital health and wellbeing technology, we find that there are a whole set of additional challenges. One of the most common challenges is the diverse sets of barriers that we need to overcome. So people living with chronic health conditions are, we consider a classically hard design challenge to work for, because within human-computer interaction, we say you've got to understand the lived experiences of the people that you are designing for. And when someone lives with a constant health challenge, it is very difficult to really envision what it's like to live in that person's shoes. We also have to deal with diverse populations. Healthcare conditions affect everybody. Medicalization tends to push designers to think of people as being their health condition, but this is very much the wrong approach to be taking. It's really a critical mistake to reduce people to the health condition that they are living with. And then finally, of course, there are ethical and safety concerns as well. At the core of participatory design is this idea of iterating on a design concept. So in a classic method, we would talk to people at the very, very outset, before we've even submitted a grant for funding to try to get some sense of what they would want us to build. Once we've secured funding, we would expand the number of people we talk to, and ideally talk to dozens of different groups of people to get initial input into what we should build. We then start to narrow down, and here the methods that we use become complex, and we have to just think on a case-by-case basis of what we want to do. Do we want to build a system prior to talking to people to show them something to focus their thinking, or do we worry that that constrains and narrows their thinking too much? Depending on the context you work in, I'm afraid the answer changes. So it's very, very hard to give a concrete, this is the process to follow in participatory design. We can only ask, what questions do we need to answer to determine what we should try doing? But anyway, what this leads to is eventually we start to build things. We start to build software prototypes. We start to build things that can actually go and run on a smartphone that somebody has in their pocket. And if we weren't in the healthcare field, the next step would be completely obvious. It would be to put that software onto people's phones and let them use it, either for a few hours in a lab setting, or ideally by taking it home and using it for a couple of weeks and then coming back and telling us what that lived experience with the software has taught them about the needs to change it. In healthcare, we hit this very awkward point, unfortunately, where when we can load the software onto people's phones isn't necessarily the time to send them home to use it, because of course you're giving them a prototype that relates to medical information. And what we end up doing is giving these very awkward briefings to people where we explain that this looks like a real medical intervention that you can use to get advice, but you can't. But we'd like you to interact with it and ask it questions as they occur to you, to use the features of it as you think about them, but don't actually follow any of the advice it gives you at this stage, because we just want to gather some feedback from you on how you feel this interface works. So this is a really awkward point to be dealing with the system at, okay? Still, we try to forge through. What I'm going to do now is talk about a few different specific cases where we've used participatory design in different healthcare related fields. And I'll talk about, the project and what we learned from the co-design process about how we needed to adapt our co-design process. So the first project that I want to talk about is the Safe Home Living project. This project led to it was a project that actually led to a commercial application that was deployed, a home monitoring package aimed at older adults. The system aims to provide reassurance about the safety of older adults living within their own home. This project was a really interesting one to work on. We focused on older adults living with or without some form of cognitive impairment in the early stages of this work. Doing participatory design in this place is really complicated. The home is a really complicated space to work in at any sort of scale. Small changes to the environments that people live in have very large knock-on effects about how they feel about living in those environments. I should also mention that this project is a great example of what often happens in participatory design, which is that we're quite often asked to drop in and start doing participatory work on a system that already exists in some form. And this comes with an inherent set of problems related to what I said before about the need for early engagement, because what we found doing this work was, just to take your attention back quite a long way to an earlier slide, in the basic design that was being done, the first question to answer is design the right thing. What is the right thing to design? And the system that we were working with at this stage was not necessarily the right thing to be designed. The project really uncovered that invading people's privacy, or the sense that your privacy is invaded, is the single largest real barrier to any in-home monitoring system. It's a fundamental challenge to get past. Pragmatically speaking, our findings often seemed obvious in retrospect if you can imagine yourself in a situation that our participants were in, but they were not obvious for the large business consortium that asked us to do this work. So very, very simple things. Like one gentleman asking us, would this sensor see the person who came back to my house with me last night from the pub? It would, yes, it would let your son see that you had a guest come over and stay the night. That sort of question had not occurred to the people designing the system. This also got us onto, or led us to, hearing a phrase that comes up a lot in healthcare design when you really build a good relationship with your participants or stakeholders and they're willing to give you their unfiltered thinking. It's a great, lovely, clever idea for someone else, but I think I'd rather be dead than use that, is essentially the summary of their attitude to this innovation. So this was a really difficult area to work in. In terms of the process, if we go back to thinking about participatory design as a conversation with stakeholders, with space for genuine disagreements, and with equal benefits and control being offered up over the process, what we saw here was a set of different challenges. So the first of these, and one that I'm keen to always re-emphasize, is that older adults as a user base are an incredibly diverse group. There's a tendency, I find, in research to think of older adults as a stakeholder group. So you have younger adults, you have people who are middle-aged, and then you have retired or older adults. That pattern of thinking is not particularly helpful to start with, but it is also paired with a second assumption, which is that as people get older, they get more homogenous as a group, when the reality by virtually any measurable characteristic is the opposite of that. So for example, income, wealth inequality among people aged 20 to 30 or 18 to 24, however you want to categorize people. Yeah, there's wealth inequality, there's income inequality, but it's relatively narrow. By the time that you get to older adults, people, let's say specifically people who are retired, what you see is that the richest people in the country and the poorest people in the country are within that specific group. Okay. If you look at people's visual acuity, again, there is a range of visual acuity across any age demographic. But when you get to the older adult group, that is when you see the widest spread in terms of visual acuity, right? And this goes on, whatever characteristic you might want to look at, the older adult group is the most diverse group. So finding a, inverted commas, representative sample for them is nearly impossible to do. What you instead have to do is target a specific group within the older adult community to have any chance of drawing a sample that speaks across a range of conditions. Another very important thing to consider is how your recruitment methods might bias your sample. So we employed mixed methods for recruitment here, and hopefully this is something that you've come across in research stuff already. But obviously, simply using phone calls to access everybody does not get you access to people who might have hearing impairments. Simply using online recruitment obviously only recruits people who are online, and that's within this age groups, most of them are online, but it's also the age group with the largest number of people who are not online there. And obviously then there's postal recruitment as well, but when you go through that process, again, you hit these barriers around the fact that some people don't have fixed addresses. So there's lots of different challenges in recruitment going on. The space for genuine arguments is interesting here. How do you support people disagreeing about things that you place within their home? So for some people, this is a very, very sensitive topic, and they're very willing to have quite vigorous disagreements with you about what you put within their own home. And that's great. That's exactly what you want within this process. For other people, there's something of a sense that having a researcher come into your house and put sensors within it, because that's where we got to, is unpleasant. It's intimidating. And obviously we we really don't want to do that from an ethical point of view anyway. But there's also the sense that you shouldn't be disagreeing with these people because they are seeing your personal data being collected. So building a relationship with the people that you work with is also a critical element of this work. And it's something we worked very hard to do. We had 6 meetings with each person that we worked with on this project. We brought them in for some group sessions, but primarily we held individual meetings with them in their own homes where we went out to them. And as I say, we did actually test the system because people can't envisage what it is like to be monitored easily. So having the devices within the home, monitoring them, gave them a whole fresh range of insights into what the system was doing. Finally, there's of course equal benefits in this process. So how do you support learning in this context? And this is a recurring theme. What do you do when the medical advice and the desires of a patient, or in this case, the subject of the monitoring, start to diverge? So this question keeps coming up over and over again. But at a certain point in these design processes, what we constantly see is that at a certain point, the person who is being the subject of the technology, sometimes we try to, using the term patient isn't always right here, but the person who is the subject of the technology has a very different desire for it to the medical professional who suspects that this will be a beneficial thing to design and develop. So how you negotiate these problems is really quite challenging. So that was one particular problem area that we worked in. The next area that we started to focus on was the use of monitoring technology to support safe walking for people living with dementia. So what you're seeing on screen at the moment is some of the early prototypes of high-tech system designs that we conceived as being a way to help people who were in the early to moderate stage of dementia and were still able to get out of the house and walk safely, but were losing confidence in doing so, not because of the specific barriers that dementia was posing for them, but simply because of their fears of what might happen. So this work is grounded within the idea that safe walking is a benefit. Again, I'm not quite sure for the audience that I'm talking to whether this is old hat or something relatively novel, but the work is grounded in research, particularly set within the context of the UK, that shows that the benefits of traveling outside unattended independently while living with dementia are enormous, essentially. The idea obviously is grounded in concepts of person-centered care that we see from people like Tom Kitwood from the 1990s and earlier pioneering. And it's also grounded in research by Louise Robinson at Newcastle University, sorry, Dame Louise Robinson now at Newcastle University. So we're asking this question: what can we do to help you feel safe going outside? What is it about the perception of risk that is stopping you from going outside? What is it about this that means that some people feel comfortable taking this risk? Who's allowed to take a risk and who isn't? These are quite important questions that you see come up in healthcare systems, I think, as well. But here we're really making that question quite concrete in what we're trying to address. So we were asking, what can we do to support you? The participatory design process was really interesting here. What we saw while we engaged in the process was that people's views on safety change as you empower them to make decisions. So this is, I think, quite important for any healthcare provider looking at participatory processes to be aware of. But essentially, what we observed was, and I think that this is common not just among people living with dementia, but anybody who has risk managed for them. What we saw was that initially, when they were not empowered to manage risk, when people couldn't realistically go outside, or their caregivers were strongly against them going outside, or these people lived independently, but they had an occupational therapist or a support worker visit them who advised against it. When they were not empowered to make the decisions, they were quite cavalier about safety risks. However, as we developed this work and as we got to a point where we had functional systems that could help people if they became lost, that they could carry with them, what we saw was that their attitudes shifted towards risk as they had to essentially take responsibility for managing it. So this is something that we've seen over and over again. When a problem is, pardon me, when a risk is hypothetical, when it's a system that you might design that might allow someone to do something, their attitude towards risk is, I'll take that risk. I would love to have that opportunity. As things become more real and as they realize you might produce a prototype that is functional and will let them walk outside and summon help if they need it, they become a bit more cautious about risk. They don't stop wanting to do it, but they feel like they need more support to understand the risk they're taking on, and they need more understanding of the safety measures that your tracking device is putting into place. Another critical element here was the importance of integration into routine as opposed to low maintenance interventions. Put very, very simply, a mobile phone that has a 24-hour battery life will never run out of battery, because within your routine, you will plug it into charge every night when you go to bed. It's absolutely fine. A mobile phone with 3 days of battery life is far more likely to run out of battery because you don't remember to plug it in every night. You have to make a specific note one night in 3, which doesn't fit within your regular routine to do. If we ever get mobile phones to the point where they last for 7 days without a recharge, then we might see those become a bit more useful, because at that point, maybe there's a weekly routine that you can integrate charging them into. You know, you take the bins out on a Sunday night and then hop on the shower and go to bed. Maybe that's when you remember to charge something. Integration into routine really works in those spaces. Medication follows the same principles, obviously. You know, medication that you need to take daily is relatively easy to remember. A medication that you take once every 36 hours is very difficult to remember to take. Finally, we also came up with this quite important idea around stigma, and this is a common barrier to healthcare technology adoption. It's not up there with concerns around privacy or intrusiveness, but it's still a pretty high priority for most people. They don't want to carry devices that mark them out as living with a disability, usually. It's not always true, but most of the time. And so we came up with these approaches: designed, disguised, or discreet. You can make something that is designed, something that looks aesthetically pleasing. The notebook at the back there is an example of that. It's something that looks pleasant. It's something that looks considered. You can also make something that is discreet. So you can see the size of the electronics that we're working with there. That option wasn't really in place for us at the time that we were doing this project. Finally, you can make something, though, that's disguised. So if you can build your system into something that looks like it's meant to be worn or carried, something that looks like something else, then that's fine. The left-hand corner shows what we call the runner's armband. It's an armband that was designed to look like an MP3 player or an arm-worn mobile phone that would track their movement and allow them to call for help if they needed it. The central mobile phone is an example, again, of a software version of the system that, again, just looks like a conventional mobile phone that people might be using. The final project that I'll talk briefly about is, a project that we did looking at the sensitive challenges of people from neurodiverse groups. So the images that you're seeing here, just to explain them very quickly, on the right are some of the prototyping activities that the neurodivergent communities we were working with did. So they built these pieces of technology with a little bit of support from us rather than vice versa. On the left, you see some of the design material we generated. So this was design material looking at where a device might be worn or carried and where it would be irritating or beneficial to carry these devices. So what was this project about? We were interested in, we still are, this is, I should say, this is ongoing work. Benjamin Afua at Monash University in Australia is leading the work in this area in their PhD. So we were interested in working with neurodivergent groups. They have lots of interesting but very sensitive challenges that they don't necessarily feel comfy discussing. Sometimes that's especially true, I'm afraid, working with healthcare providers. That, you know, because of a long history of challenges being understood in that community, and it's a community now that has, in fairness, got mixed views on healthcare because of this. So our question was how we can engage with this community. Our lead designer comes from this community in this place. So, they want to take on this challenge for personal reasons as well. But there's also a lot of research questions about the method that you might employ to do this. What we ended up doing with this community was not exactly conventional participatory design. It was what we sometimes refer to as making. So what we did was we gave them access to a large amount of electronics, a makerspace, 3D printers, laser cutters. I should say that we're working with a group of people here who are based within a university setting. So they're students and staff within a university, so more educated than you might classically expect. But we gave them, after doing a bit of design work, access to this space, and we asked them what they wanted to build. And what we hit upon for the first iteration of a high sensitivity challenge was forgetting things. So very common problem for many adults who are neurodiverse is mislaying, forgetting, or leaving behind important items. The designs that I've showed you were all around building tracking devices. So the most obvious there, bottom right corner, that small key fob has a tracker built into it that will alert you if you leave the room without taking the key with you. The little cat is a little tracker that you can attach to anything that you want to make sure you don't forget that does the same thing. What you see on the left, to explain a little bit more, is discussion of the places that you might put a watch or another device that would buzz when you left behind one of these essential items. This process was, again, super interesting for us. The conversations with stakeholders were really fascinating. They obviously take place within a specific cultural context, and we were lucky to honestly not have healthcare practitioners working directly with the community we worked with, because a large amount of the discussion that we had was around the problems that they felt they had being taken seriously by healthcare providers. And these sorts of questions about who you put into a room and what role you say they have are really important to consider in participatory design. More generally, we know that if you put patients and doctors into the same focus group to discuss a systems design, you will see the patients frequently censor themselves and don't say certain things in front of the clinical staff because they view them as having a certain degree of authority. Going to say very quickly, not everyone does that. I'm sure that everyone has some experiences where it seems like it's quite the opposite. But for some people, there's a very deep respect for people from medical professions and a reluctance to disagree with them in those settings. So forming groups is important to consider. Genuine disagreement in this setting is also that needs to be considered something you need to think about carefully. So disagreements with, genuine disagreements about how something should be done need to be negotiated carefully when you're working with some neurodivergent adults. Again, not everybody, but it is more commonplace than it might be with other groups to have arguments that can really easily spin out of control. Here, the experience of the lead researcher as somebody from that group was pretty essential, navigating these questions. Finally, the questions around equal benefits really came to the fore in this process. So the group that we were talking with were very used to having people parachute in to do a small amount of research and disappear, taking the work that was done with them away with them, never to be seen again. So this was a process where we actually had a member of the community leading on the work. They're still within that community, even though this phase of the work has finished. We're doing things like discussing commercializing some of the designs that emerged from this process. That's still an ongoing process. It's not quick to do, but the community who generated the ideas are still in the loop on what's happening there, and that's a really important aspect of doing this sort of work successfully. So that's a really rapid run through of some of the research that I've done within this area. I really appreciate everyone taking the time to come along and listen today to me speaking.